So the specific design of this cushion has a top edge that is flat and creates a sufficient shearing surface so that if we're adjusting the spondy, the whole concept of what we're doing is taking with a motion unit where one of the vertebrae has shifted forward slightly, depending on the degree of the spondy, whether it's a type 1, 2, or 3. That's pretty much the only ones we would work on with this technique, but they're the most common ones that we would find in our offices. The whole idea is if that pars has fractured and it allows the vertebra to shift anteriorly, we want to get that patient supine and have a shearing surface that allows the vertebra to shift back. Again, it's micrometers, but it's enough to shut down that spasm of the quadratus lumborum that is giving them that acute antalgic lean and acute discomfort. So this edge of the table is, other drop tables that we've used that have a cutout for male anatomy, it makes you have to really work harder to sufficiently get a surface that's going to have that shearing effect. So we get the base of sacrum right here, which leaves L5. Usually most spondies that we see are L4, L5, or L5S1. So we basically change it up based on the specifics of the patient, but we typically get the base of sacrum resting right here, and then this surface is sufficient to have a shearing effect that then when they're in a supine position, it allows us to drive the vertebra back to a more neutral position, and it almost immediately mitigates the discomfort. And that's when a patient gets up off the table and is suddenly feeling miraculously better. So what we can do now is, so if I reach down here and I turn the lever to allow for some flexion in the table, I can lower this lower section, which then facilitates the antalgic lean of a patient as they come in. If they can't stand up straight, they can kind of make their way right to the table and go right down without having to be in any kind of a straight, more so extended position on a table. So if we could have Laura over here just lay face down on the table. So this position of the lower portion facilitates that anterior antalgic lean. Some patients it's more acute, so you can have a little bit more flexion, some less, depending on their comfort level. And so for the assessment component, first of all, if you're not sure it's a spondy, you're going to assess them somewhat in a prone position eventually. If there's any other issues occurring that you need to address, whether it be sacroiliac instability or lumbar issues, you're going to want to evaluate them in this position while still accommodating the spondy. Again, if they're in a straight prone position, it's really going to work against, and it'll continue to have that QL spasm binding up, and they'll be in more and more discomfort the longer they lay here. So even still, I won't keep them in this position for too long. Once we do whatever we need to do in this position, I'll have them transition onto their back, and usually as they transition, if they're severely acute, we'll either help them up off the table, change the table to a more of a straight position, or sometimes as they transition, I'll just change the position of the table, pulling the lever and straightening it out to a more of an even plane. So Laura, let's have you flip over onto your back. So as she turns, I'll just kind of straighten this out and then lock it in. And then I'll have them shift and slide down to where we're lining up the base of sacrum right over top of that upper surface of the pad here, so we get it right at the shearing surface. And then we'll have the patient bend their knees a little bit. And most patients with any degree of a spondy will say that when they stretch in this position into like towards a cannonball kind of pull up with the knees, that gives them some relief. But they often can't get the knees up that high because everything is in such discomfort and such acute spasm. So what we'll do is, with this table is great because the pneumatics allow you to have both hands free. So I'll come down here and turn it to the lower pelvic drop, and then I'll set it so that it's going to elevate, and I'll usually talk to the patient. The first elevation, if they're really acute, the first elevation can be very discomforting, uncomfortable. And so I'll kind of go very gingerly with that. And as we progress with this, with each drop, it feels better and better and better. So essentially what we're going to do is I'll hold the patient's legs like this, and I'll instruct them that I just want them to let these just dangle right over my arm. So they're at complete rest. And then I'll have the lower pelvic drop elevate like this. I press on the pedal, make sure I calibrate with the knob that the drop is not going to be too strong. And as their legs are passively just dangling over my arm, we'll just come down and drop through. And that creates that shearing sudden drop where L5 in this case is dropping posteriorly more towards its natural position, as if that pars interarticularis were intact. So then we come up again and we ratchet up, down a little further. And again, with the air flex, I don't have to use my hands to reset the drop. I can just keep going, slowly working this up, eventually to where we get the patient into more of a cannonball type of position. And to the patient, every drop feels better and better and better. And then we let these relax. And oftentimes with Spondy, transition from laying to sitting, sitting to standing, those transitions are ridiculously painful. So I'll often help the patient sit up and help them into a standing position. And they will often stand up erect and upright as like normal, whereas prior to that adjustment they would have had a really tough time standing upright without a discomfort.